Hello, my name is Elizabeth Rankert. I'm a current PhD student at the University of Kentucky, and today I have the privilege of talking to you about life after your dysphagia course as an acute care or inpatient rehab speech language pathologist. So, as a quick overview of what we'll talk about, I'll talk about my personal journey to acute care. We'll talk about what even is acute care and inpatient rehab. I'll just share some dysphagia intervention reflections with you and things that I've learned since graduate school. We'll go over a few dysphagia case examples, and then finally, I'll share some additional tips for success. So, a little bit about me. My journey actually started kind of by you, but in Rochester, New York, at the Eastman School of Music, where I studied vocal performance. And I knew that I always wanted to be a speech pathologist. And I thought at the time that I wanted to work specifically with singers. But since then, my course has changed a little bit. And now I really enjoy working with neurology patients. After that, I completed my post-baccalaureate at Northwestern during COVID. And then I went to grad school at the University of Illinois, where I met my mentor, Dr. Ishikawa. And I also had the privilege of meeting Dr. Noodleman back when he was a PhD student. And during that time, I realized and found out that I absolutely love research, which was super unexpected to me at the time because I came from a music background. I didn't know very much about research, but it quickly became the best part of my day. After that, I completed my clinical fellowship at OSF Healthcare, and that's very close to the University of Illinois. And during that time, I worked as an acute care speech pathologist. I did inpatient rehab, and I also did outpatient swallow studies. And at this point, I'm a PhD student at the University of Kentucky, and I also do per diem work, which is kind of like being a substitute, essentially, at the Jewish Hospital in Cincinnati. And there I still do acute care work and also inpatient rehabilitation. So, what is acute care? It really can be any unit in a hospital, and all of the patients that are there are experiencing either a new or sudden onset of a health issue that requires immediate medical attention. So, this can be anywhere from somebody in the emergency department to somebody who is in the ICU to somebody who just had neurosurgery. And then finally, those who maybe are a week post-op and a bit more medically stable on like an ortho unit or a step-down unit. Admission lengths for these patients can really be less than 24 hours if they're only in the emergency room, or they can extend past a few weeks. So sometimes you will follow a patient at the stage, I mean, again, anywhere from seeing them one time to possibly a few weeks. The care team is typically pretty big, and often you will only interact with certain members of the care team. So, typically for every patient, there's an attending or a head physician that oversees their entire level of care. There are nurses, and these nurses will switch every 12 hours or so, though they do try to keep a patient with a nurse to help with continuity of care. You may have surgeons, a social worker that is overseeing the case. You'll have nursing assistants, which are the head or your hands and feet. Um, and we'll go over that a little bit more later. Patients may also be seen by occupational therapists or physical therapists, and then any other specialist. And this whole care team may also shift as a patient goes from unit to unit. So, a patient, for example, may be in the ICU where they'll have a certain care team, then they'll transition to neurocritical care where their care team again will shift. Typically, though, the SLPs, again, depending on the size of the hospital and things like that, they'll try to keep you with the same patient again to help with that care continuity. SLP primary involvement in acute care is going to be dysphagia, particularly to make sure that patients are eating and swallowing safely, especially as relates to medications. So sometimes patients will not receive their medications until we see them. And so we play a very critical and important role in the entire care team. We, of course, also will see patients for language, cognition, and voice and speech as needed too. But again, the primary role we play in acute care is actually dysphagia. And typically, we will see or follow patients for 2 to 4 therapy sessions per week. However, this also varies depending on how long they're in the hospital. And these sessions can be anywhere from only 8 minutes to actually, being an hour or so, depending on the complexity of the case. So, what is a typical day? I put typical in quotes because there truly is no typical day in acute care, and that is could be one of the joys or one of the difficulties of it for you, depending on your personality type. Usually I'll get there 7 a.m., 7:30, somewhere in there to look at the different cases. Often in acute care, you prioritize evaluations first because in order to meet certain standards, hospitals ask that we see patients within 24 hours of the order being placed. So we do, again, we prioritize evaluations to make sure that we do see those patients and we can continue and begin their plan of care for speech. Typically, after I look at cases, prioritize who needs to be seen, I make a plan, and that plan usually never happens, but a girl can dream. And typically, again, we'll see evaluations first. We may see high priority treatments or anybody that would need instrumental assessment or do instrumental assessments. My hospital does modified barium swallow studies and fees, though I personally only do modified barium swallow studies. After that, we'll have a little bit of time for lunch or documentation. Though honestly, I document as I go because after you do forced swallow or like clinical swallow evaluations, it's hard to keep everything in your head. So I typically document as I go to make sure that it's as accurate as possible. Then after that, you do more evaluations and treatments. So again, all of these are on the shorter side of things. Usually I'll spend anywhere again from maybe 15 minutes with a patient to 30 minutes. And you tend to see a lot more patients for, again, a shorter amount of time. And though that could be seen as a bad thing, oftentimes these patients are so medically unstable that they can only do so much therapy to begin with. So oftentimes the amount of time I spent with the patient is actually dictated by their own energy levels and less by my schedule. Not pictured on this are, speaking of that, all of the patient attempts or holds, coordinating care, etc. So oftentimes, again, we'll have a plan. And it will not happen simply because the patient is getting other testing, maybe they're fatigued, things like that. So often I'll attempt to go see a patient, then I may have to go back later in the day to see them too, depending on their schedule and what's happening, big picture. Pros to acute care, I personally like are that it's fast paced and that there's a variety of the caseload. So with brain injury, you really never know how it's going to manifest and how it will progress. You can guess and have educated predictions, but you never truly know. And so I love figuring out what specifically works for individual patients and then following them through that. The other thing is, in acute care, it's incredibly meaningful work. And probably we'll talk about this more later, but the most important thing you can do is to be a positive and compassionate energy or face for that patient so that when you are there. They're going through probably what is one of the hardest points of their life, and you get to walk alongside them in that, which I find to be very beautiful and very rewarding, even though it can be challenging too. But I just see it as a great opportunity to not only rehabilitate someone and change their life that way, but also to care for them in such a difficult and challenging time. Challenges can be that it's fast paced. Different hospitals will have productivity requirements. So it's good to, when you're interviewing for jobs, to ask about those and to ask what the expectations are. Typically, acute care productivity is on the lower side compared to outpatient, simply because the cases are more complicated and you need a little bit more flexibility with the fact that patients are in testing, they're unable to participate, things like that. However, within that, some hospitals can still have pretty high productivity requirements, and so it's important to look at that. And over time, your ability to meet those requirements will also improve as you get more comfortable with the cases. It requires a lot of flexibility. I've already mentioned that. Conversely, to the fact that the work is very meaningful, it can also give you some compassion fatigue. So, learning how to separate yourself from some of these complicated cases, it can be challenging and is a learning curve, especially, I mean, as healthcare workers, we're compassionate people, right? And so finding that balance for yourself is pretty critical, but also recognizing that sometimes what you're seeing is sad and just taking the time to process that and to grieve it too. When you first start, in particular, there's a lot of information overload, especially because these patients are so complex. So, learning how to parse through the information, see what's important, what's not important in the chart review, is a skill and just takes time. And then the other challenge is that there's care team turnover, which I've already talked about a bit. But because of that, you may only communicate with one of the nurses the patient has, and they have had four or five. So doing your best to educate those that you do see and to, document well, leave resources in the room, things like that, so that the patient can have the support that they need despite the care team turnover. Briefly, I'm going to talk about acute inpatient rehabilitation. Compared to the other pictures that I showed you on the last slide, you'll see that these patients are up and at it, moving a little bit more, and that is, they kind of show what acute rehab is. So, this is for patients, again, that have recovered but are still not quite meeting the functional needs that they need to or goals that they need to return home safely. And in acute care or acute care units, you'll have patient rooms that typically have a bathroom, you'll have community areas, kitchens, and therapy gyms. For these patients, it depends on their insurance, but admission is anywhere from 4 midnights to 3 weeks. I've even seen patients for 2 months. So it can be a long time depending on what insurance will pay for. The care team it's overseen by a medical doctor who manages the patient's care. There will be nurses, though in this case, you will work with a smaller set of nurses and the patient will often have the same nurse pretty consistently. Same with nursing assistants. They will have a social worker that plans their discharge, therapists being PT, OT, and speech. And then they may also see other specialists too. So it's really, there's more of a shift in rehabilitation and less on evaluation in rehab. The structure of it is that the patient must be able to sustain 3 hours of therapy. So that would be any combination of physical therapy, occupational therapy, and speech for 5 days a week. And speech involvement is truly anything that that patient needs. So again, we still are prioritizing dysphagia just because a patient's oral intake too affects their ability to participate in therapy and to recover. So dysphagia is very critical, very important. Second to that would be cognition and language, again, to help with that rehabilitative process. And then we usually also participate in weekly care conferences, so there's more of a structured type of participation for the SLP and then also schedule for the patient. Briefly, I won't go over all of this. The schedule is pretty similar to acute care, except for the fact that it is more structured. So, usually the day before, you will receive a schedule saying you are going to see this patient for 30 minutes. You'll see this patient for an hour at this time, and it's coordinated again with PT and OT. That would be the main difference, and then also the daily care conferences and reports. Then in some hospitals too, once you finish your acute care day, you may also end up, or not acute care, when you finish your inpatient rehab day, you may also go help out with acute care as needed. Pros to this. are that you have more opportunity and time to really collaborate with the patient and then with caregivers too, because you're working with patients often every day of the work week, but 5 days a week for at least 30 minutes to an hour, you end up really getting to know your patients. And so that's really special because you can make meaningful and functional goals for them. And you also have a much deeper understanding of their learning style. There's a lot of variety, again, within and across patients. So, because again, you see them every day, you spend so much time with them, you get to see the variability in their own capacity and how that may change day to day. And then also, you'll have a variety of different functional levels for patients. There's a really wonderful opportunity, I'd say, for deeper interdisciplinary collaboration. In some places, physical therapy and occupational therapy may co-treat with speech. In the hospitals that I've been a part of, we've often consulted one another. So I'll have, a PT come to me and say, "Hey, I noticed X, Y, and Z about this patient as a heads up," or I can do vice versa. I've also worked a little bit with them, specifically related to like cognition or with OT, making feeding devices or modified devices to help with feeding. Um, so there is just a beautiful way to foster deeper interdisciplinary collaboration with them. Your schedule is more predictable if you like that. And typically, you get a little bit more extended documentation time because when you do an evaluation, it's pretty extensive. You'll be often looking at, dysphagia, cognition, and language, something like that. So you need a little bit more time to make a robust evaluation. And then the caseload itself can fluctuate and it really depends on the needs of the unit. So some weeks or days may be very busy, and other days there may not be patients that need speech on the unit, and then therefore your caseload's lower. So I like the ebb and flow of rehab. The cons of it are because you spend so much time with patients and with families, sometimes you do get in the middle of complicated family dynamics or those are exposed, particularly because these families are under stressed. So during care meetings, coordinating care, discharge planning, you may be a part of that and be a part of those harder conversations and finding ways to support and advocate for the patient within those. Similarly, again, to acute care, you may have compassion fatigue. These patients are often depressed and going through some sort of grieving process because of the loss that they're experiencing. And so, a big part of your job is actually walking through that with them, but also being a beacon of hope without creating false promises or things that you can't commit to. And then the last con is that insurance rules. So some patients you may feel really need more therapy, but you can't necessarily provide that to them or you can't charge it necessarily. And then also some patients may be fatigued or may not necessarily want to do therapy, but in order to stay on the unit, you need to at least attempt 3 times to give them or to meet their therapy minutes. So there will be times I will have to go try and see a patient, yeah, 3 times, trying to meet their minutes to make sure that they get to 3 hours for total PT/OT speech, but playing my part in that. Now let's talk a little bit about dysphagia now that you know about acute care. And yeah, some of that may have been a review, but hopefully it was helpful or it can help a few more things to stick. When I first left grad school, I thought that dysphagia therapy was pretty black and white. So I thought, you would see a patient aspirate on an MBSS and that aspiration would be consistent. It would be clear cut. Compensatory strategies would either work or they wouldn't work, and everything would make sense and you would know your recommendation. Probably leading to, again, the least restrictive, maybe a modified diet, but again, that everything would be very black and white. However, the reality of dysphagia intervention, evaluation, treatment is that patients fluctuate all the time, and different etiologies will lead to different impairments and different prognoses. So Patients may intermittently aspirate, or their function may change throughout their hospital stay, even day to day, even minute to minute. I learned that every patient is unique and that plans are individualized and change too. So, in order to accommodate patient needs, obviously you need structure, you need a concrete plan, but you also, that plan is fluid and your treatment, your evaluation, everything kind of has to ebb and flow with the state of the patient. So, kind of to talk a little bit more about this, more specifically, swallow function is a product of three different things. We'll go through them. It's a product of the individual, and I'm talking a moment like swallow to swallow. So that could be their etiology, it could be comorbid conditions, their prognoses. Do they have a neurodegenerative condition? Are they likely to recover some function? Their respiratory status. Are they on a tons of oxygen? Are they on a high flow nasal cannula that impairs their sensation or puts them more at risk for aspiration pneumonia? Their mobility levels. Are they, laying in bed constantly or are they moving around? Again, limited mobility can be a risk for developing aspiration pneumonia. Oral care is huge because even patients, and we'll talk a little bit more about this later, you can aspirate your secretions, and that can be pretty common. So if your secretions have a lot of bacteria, that can again put you at risk for aspiration pneumonia. And depending on where you work, you will likely be surprised by how little people actually brush their teeth and take care of their mouths. I had one patient that I asked him, I said, how often do you brush your teeth? And usually you have to ask them like that specific question. And this one guy's like, "Ugh, last time I brushed my teeth was the Vietnam War." I was like, oh, geez. So one of his goals was actually to improve his oral care because he was aspirating thin liquids and therefore his secretions. So no matter what we did, no matter what diet I put him on, he would still be at risk of that because, again, of his poor oral care. So that's huge. Sensation critically important because we need sensory motor integration in order to swallow. So if a patient, can't feel, they're going to have a hard time manipulating the bolus. They may have difficulty initiating the swallow, and they may not feel aspiration or a lot of pharyngeal residue, to name a few things. Structural or anatomical changes. So that could be anywhere from, neuro changes to also maybe someone is missing their teeth. Maybe someone had a laryngectomy 20 years ago. Things like that. So being aware of someone's structural baseline and what a normal swallow may look like under those circumstances, or maybe how they could anticipate differences. Cognition is huge. Can someone, and especially with brain injury, can someone attend to the task? Oftentimes, it's very hard for them to do that. Can they remember the strategies that you've given them to do? Can they sequence? So, if they can't remember, can they look at a piece of paper with their strategies and sequence eating, looking, swallowing, all that stuff? Are they able to do that? Uh, do they? Sometimes with attention, people will forget that they have food in their mouth and that they need to chew, so that can put them at risk. Um, Things like that. There's a variety, but cognition is actually hugely important in terms of dysphagia intervention. Also, would they be stimulable for therapy? That's another big one. Receptive and expressive language, similar there, but can they understand the recommendations that you're giving them or that others are giving them? Energy levels, because these patients almost all the time have gone through a traumatic event and their body is healing, they are going to be exhausted. Typically, especially when they arrive to inpatient rehab, the first few days they are pooped because they're doing 3 hours of therapy all of a sudden. They're asked to sit up for meals, all this stuff. So, being mindful of the patient's energy level and how that may change throughout the session too. So, maybe if you are doing a session, you do dysphagia first or you take breaks to ensure that they have adequate energy to participate safely. Are they motivated? Do they care? Some patients do care, some patients don't. It just depends. So, like, do they care about improving their swallow function and will they adhere to the recommendations that you're giving them? That may change, it changes the conversation in terms of, how restrictive you may have to be, versus what extra documentation you need to do if they reject your recommendations. Grief and mental health, often again, these patients are grieving, and sometimes that will affect their participation or their willingness, their willingness to participate in therapy, to do it. So that's just something to keep in mind. Then also lab work, so looking for risk of infection like elevated white blood cell count, chest x-ray, very similar. Are we seeing consolidation in the chest? And then also looking at other needs. So if a patient, for example, really has to go to the bathroom, they are not going to be interested in participating in therapy and they're going to be distracted. So before you begin therapy, really looking at, okay, do they have other needs that I need to address so that they can meaningfully participate and improve their swallow function or swallow safely? Other needs may also be, preferences. I had one patient, he was in the ICU having a really hard time. I don't remember what his diagnosis was. And the nurses were like, we just can't get him to do anything. So I go in, and he, of course, refused his swallow evaluation, but was NPO at the time, so he couldn't have any oral intake. And so I said, okay, what food sounds good? And he was like, chocolate pudding. And I only had vanilla pudding. So I had to, I had to wear a bunch of like protective equipment too. So I had to get out of the room, kind of inconvenient, whatever. Go get him chocolate pudding. Come back, it's chilled. He's like, I want lukewarm chocolate pudding, not refrigerated. Do the same thing, but then he participated. So sometimes taking a few extra minutes or inconveniencing yourself a little bit can make a big difference in terms of a patient's participation and then their ability to eat again. Swallow function and treatment is also influenced by the environment. So, like we already talked about with cognition, background noise can really distract patients. Same with like if the TV's on, really anything that is remotely interesting or stimulating will be distracting. Are there objects on the table? Are nurses walking in and out? All these things can affect swallow function and someone's ability to swallow safely. So, with that, trying to reduce distractions, especially in the early phases, and if someone has a cognitive impairment, is critical to ensuring that their swallow function is safe. Um, with that too, sometimes caregivers will be, chatty, 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 talking to the patient while they're trying to swallow, talking to you, things like that, and that can put the patient at risk. And then the task type. So, the type of bolus you're giving them, is the patient, at 45 degrees in bed? Are they at 90 degrees in bed? Sometimes I'll have patients that are can't say for sure because you're not doing instrumental, but you walk in and they're like laying down, shoving ice chips in their mouth, and they're coughing all over the place. But if they were to sit up, they'd be okay. So looking at those kind of things and being mindful of how they may contribute to swallow function. The rate of bolus flow. Are they drinking through a cup? Are they drinking through a straw or a modified cup? Sequencing and feeding support. Are you cueing them or do they have to remember? If they have to remember and there's increased cognitive load, that can affect their swallow function. And then also use of compensatory strategies. Those may, again, help. Or if they have to remember them and implement a bunch of different things, maybe hurt. So really, swallow function, truly minute to minute, and then day to day, week to week, month to month, is a combination of the individual, the environment, and the task you're asking them to do. And it changes over time. So, with all that, your role is not just saying, okay, are they coughing? Are they not coughing? Are they aspirating? Are they not aspirating? It's putting all of those little pieces together that we just discussed, to create a patient-centered plan that is fluid and can change based on the patient's needs. So, next, I'm going to go over a few case examples that kind of show if someone had the same MBS, but how you would do things differently based on who they are. So let's say we have patient number one is seen with a wet cough that worsens during meals. These are all inspired by true stories, too. And their MBSS shows that they have intermittent aspiration of thin liquids only. And then they have moderate oral pharyngeal residue with graham cracker that can be cleared with a nectar wash or a liquid wash. This person, okay, has Parkinson's disease, which is neurodegenerative. They are already on oxygen with limited mobility. Their wife assists with oral care, but without that, oral care is limited. Cognition is impaired, so the person can't necessarily follow instructions very well or very consistently. They have fluctuating energy levels up the wazoo, a weak cough, an impaired sensation. So they may have a delayed cough with aspiration, or they may, I've had patients, with quite a bit of oral residue during their MBSS, and they're looking around and you try to cue them to swallow and it takes some time. So if you just look at the imaging, it doesn't tell the whole story. It tells part of the story. And so it really is important again to look at the individual and to figure out what your recommendations may be. I'll give you a second to think about what your recommendation may be, and then I'll show you what I would do. So for this patient, I ended up recommending a minced and moist diet with nectar thick liquids during mealtime. And that was because they had a really hard time chewing. And often a lot of the bolus was left unchewed for that patient, which, given their impaired cognition, they're not necessarily swallowing to clear it, could put them at risk for choking. So, really, it's to reduce the risk of there being an obstruction in the airway. And then I decided on nectar thick liquids for this patient during meal times to reduce the risk of aspirating the minced and moist food. However, also with the help of his wife doing oral care and then implementing the Fraser water protocol so that this patient still has access to thin liquids and to ice chips for pleasure. At this point, we wouldn't recommend ongoing therapy besides education, making sure that the patient is tolerating the food well and that the wife or staff are able to assist the patient simply because he was unable to participate in therapy in a meaningful way. He wasn't very stimulable due to his cognitive deficits, and yeah, he has a neurodegenerative condition. We'd also recommend that they would follow up, maybe in 6 months to a year or two, to also monitor and see if our recommendations would change for the patient. But in this case, it was critical for us to, share our recommendations with the patient to the best of um, our ability and his understanding, but then also to talk to his caregiver too and say, hey, here's the risks. Here's why oral care is really important. Here's what we would recommend at this point. However, if things worsen, if we see that he's starting to cough a lot with meals, things like that, we reassess. We talk about goals of care. So there's a lot of nuance than just reading the MBS. Now let's say we have the same MBS. Okay. But this individual is post brainstem CVA, and it's been 7 days. They're on room oxygen. They have limited mobility at this point, but they're working with PTOT. They need support with oral care from staff. They're partially edentulous. Their cognition is intact, but they have fluctuating energy levels, and they're motivated. So this case is a little different. Again, there's a similar amount of control over the oral care. They need help from staff, but they are motivated. They do not have cognitive impairment, and they're beginning to work with PT and OT. There's a lot better prognoses for recovery and regaining mobility. So, what would you do? I would say that there are multiple options. So for this patient, it would kind of depend on their ability to sequence and work through the compensatory strategies. A more conservative move could be, and I'll talk about this a little bit later. There's a program called MDTP, which is a specific, it's a framework to use for dysphagia intervention that I found to be very helpful. Under that framework, you would have someone begin with a nectar thick liquid with meals. I would put him on a regular diet because he didn't aspirate with the solids. However, if that were difficult at the time, we may start with soft and bite sides, gradually upgrade to the regular. I would talk to the patient about that and still implement the free water protocol too. So, water away from meals after oral care. Again, to give the patient access to water, to thin liquids for quality of life. If the patient was really responsive to compensatory strategies like a hard swallow or effortful swallow, help to clear or to prevent the patient from aspirating. Maybe a chin tuck works. You could use those and phase them out too, instead of starting with the nectar thick. So there's really a spectrum of options, and neither are right or wrong. It's really using your clinical intuition to figure out, okay, what is best for this patient? How do we move forward in rehabilitating them? I will say to the best of my ability, and I almost never actually put patients on thickened liquids to the best of my ability. And if I do, it's usually temporary and rehabilitative, and there is supplemental free water protocol. Simply because it can be more dangerous to aspirate thin liquids, there can be greater health complications, and there's not necessarily associated benefit with thickened liquids. So, with that, and in terms of quality of life, maintaining nutrition and hydration for patients, it is thin liquids are better, but they can be used in certain thickened liquids can be used in certain cases as needed under your discretion. Last two we'll go through kind of faster. So let's say we have a patient. My recommendations came up. Anyway, all right. You have a patient that aspirates with everything but coughs. And this patient had a brain hemorrhage. Again, they're room air, limited mobility. They have staff support. That should say mild attention deficits and fluctuating energy levels. Everyone in the hospital has fluctuating energy levels and a slightly weak cough, but their cough reflex is still intact. I would begin this patient. They probably at this point would actually already have an NG tube. I'm just guessing, just to receive medication and nutrition at this point. But I would keep the NG tube and keep the patient NPO, but again, give them ice chips for pleasure after oral care or small amounts of water, and then begin a modified version of the NDTP exercise or swallow exercise program that I'll go into in a little more detail. But in this case, our goals would really be rehabilitative for this patient, and we would do our best to keep the patient safe while improving their swallow function. Conversely, we have another patient that aspirates with everything. Same thing. You could say it's the same swallow study. But this individual has Parkinson's, limited mobility, weak cough, impaired sensation, limited awareness again. And again, Parkinson's is neurodegenerative. For this patient, if they're aspirating on everything and people are more at risk of developing complications, respiratory complications from aspirating thickened liquids, we would still put them on a modified diet to avoid choking on the food, just like true obstructions to the airway, anything that would put that patient at risk. And then also we would continue actually with thin liquids instead of with nectar thick, again, because there's a greater risk of respiratory complications in this patient's particular case. We would also spend a lot of time talking with caregivers and the patient about comfort care, pleasure feeding, explaining the risks of aspiration to them, but also balancing this with quality of life. Because in this patient's case, if the Parkinson's has progressed, or let's say they also have comorbid dementia, the goals are not rehabilitative at that point. That patient isn't going to get significantly better. And they may have greater health complications by having, a PEG tube, NG tube. Oftentimes, patients will try to pull them out. It's very confusing, and it does not lead to good quality of life. So, in this patient's case, we would talk more about comfort care, quality of life, and letting them, being mindful with feeding, coaching family, how to best assist this patient with safe feeding, but we would keep them on thin liquids and just a slightly modified diet for safety. So as you can see with all of this, really the pieces that are the most important again are going to be those individual differences and what we observe outside of just the instrumental assessment. Instrumental assessments are huge in showing us where the impairments may be, what may be a least restrictive or safe diet. But all the other pieces that go into that too are like, is the patient distractible? What is their cognition like? Can they adhere to goals? Are they or adhere to a therapy program? Are they motivated? What's their sensation like? What's their prognosis? That tells the full story, and really, it's our job to put all of those pieces together and to discuss options and risks, etc., with patients and family. Last, I'll leave you with a few additional tips for success and things that I've talked to both my coworkers who have grad students about and things that I have just kind of learned along the way. We've already talked about this, but reducing distractions is huge for evaluations and treatment. Building rapport with patients and caregivers, and then also staff is huge. Like I said, will probably only be there 8 minutes to maybe an hour of their day, and the other 23 hours they're receiving care from other people. So it's really important to develop good foundational relationships with nurses, nursing assistants, etc., because those are going to be the people that are feeding your patient, interacting with your patient, and may know more about what's going on than you do in that 8 minutes. So I love to, talk to nurses, talk to staff, and say, how is this patient doing? How did they take their medicine today? How did lunch go? Were they eating their food? Did they like it? Did they hate it? What's going on? And with them, you can work to create a better plan and then also to educate staff. That being said, too, it's really important, again, to develop that relationship and to assume positive intent with caregivers, with staff. Everyone is doing, the best that they possibly can, and sometimes they just don't know. So I go in there, I never assume malintent, and I try to approach those conversations with compassion and then also explaining the reasons why I'm saying what I'm saying. As a quick example, I had a patient that was like, you know, I've been coughing with my thin liquids, but they gave me this numbing spray, and now I don't cough with thin liquids. And so what was happening was the patient was aspirating with thin liquids, but the nursing staff just thought that she was sick, so they gave her a numbing spray, like a throat spray, to numb that sensation to reduce her cough, which in turn was reducing her sensation to the aspiration. Not good. So I said, hey, this patient said this to me, and based on what I was observing, it's quite possible that the patient was actually, the numbing spray is reducing her uh, sensation to the aspiration. And so it'd be best if we could take that spray away. Um, from her. And I explained this to the patient too, and it's just like, oh, that makes sense. But sometimes people don't know, they're trying to help and they don't quite do the right thing. So it's important again to assume positive intent. The other thing I'll say too is usually you're a guest on either that unit or in the radiology suite. And so it's important to remember that you are a guest on someone else's floor and to be very kind and accommodating. And then you'll have a better time, they'll have a better time, patients will receive better care. In my one picture right there, it's Robin, my radiology tech from my first hospital. And yeah, we had a great relationship, and I'm super thankful for that because we were able to, again, provide patients better care because of it. And then use your toolkit. At the very end of this, I'll have a list of resources that you can get to with a QR code. But especially when you're starting out, but all the time, talk to your colleagues about cases. Um, when in doubt, get an instrumental assessment if you're able to. Participate in continuing education when you have holes. And then continue to find objective and subjective outcome measures that apply to your population. I, again, attach some that I've used in the past and that I found to be pretty helpful in terms of monitoring patient progress. Yeah, and then look for standardized protocols or materials. So that could be, using the MBI SMP protocol for MBSS, the Yale Swallow protocol for swallow screenings, etc. A few more. So for this one, really prioritizing functional treatment. So, the one program, I guess, during my CF, I realized that there were some holes in my dysphagia intervention skills that could be better. And so I talked to some friends and colleagues at another voice center, and I asked them, what should I do? What would you recommend? And they said, have you heard of the McNeil Dysphagia therapy program? And I hadn't, but the premise of it is to treat swallow through swallow using principles of exercise physiology. You may have also heard of like bolus-driven therapy, which is a variant of this. But with MDTP, um, you gradually increase the variety and types of bolus, and you give patients a lot of practice through actually eating and swallowing. And though I can't go into the specifics of the program because I had to sign a non-disclosure agreement, it has been incredibly helpful, and the principles have been incredibly helpful in the way that I've treated patients and also their success and rehabilitation. So no one is like funding me to advertise them, but I would highly, highly recommend looking into it or looking into variants of bolus-driven therapy for that reason, because the only way to really improve at something is to practice actually doing it. And so that is one way to do it. We've already talked about this, but considering the whole patient, we've talked about the Fraser free water protocol. A really big fan of that. It's a safe way for patients to have the pleasure of thin liquids, even if they have a feeding tube, they have to be NPO or they're on thickened liquids. And then we've talked about this too, but notice subtleties in the room. So, is the patient too fatigued to safely participate? Do they have a strong cough reflex? If they're very lethargic, can they do a volitional swallow before you give them any food? Sometimes patients are not able to actually have any swallow movement, and then in that case, it isn't very safe to give them food, give them PO. Look at the patient schedule. So maybe patients are too tired because, oh my gosh, they had 3 tests before you saw them. It may not be the best time to evaluate them while they are super fatigued. And then also other clinical indicators of aspiration. So that could be if a patient can't communicate, maybe they have a facial grimace when they aspirate. Their eyes may get teary. I've seen delayed cough, throat clearing, or change in respiratory status. So sometimes a patient won't just cough. But that doesn't necessarily mean that they're silently aspirating. It could be that there are other clinical indicators. And then embrace flexibility with all of it. You'll need to be flexible either way, and so embracing it and enjoying it um, helps a lot. And the last thing that I will leave you with is that often, and I've actually drawn this for patients probably on like a weekly basis, but we often think of success for our own careers, our own learning, or for patient rehabilitation as being a positive, linear relationship, when really success is all over the place. And it's really critical for patients to be aware of this because in the day to day, they're going to take 2 steps forward, 1 step back, and really understanding that they still are making progress and that they still have time. Because even if a patient has only been in the hospital for 2 weeks, they are still in the early, early stages of their rehabilitation journey. And so it's important. for them to have compassion on themselves, for you to have compassion on them, and then for you to have compassion on yourself too, as a learner and as you continue to develop as a clinician. Here, last but not least, are a few different resources, and I have them as a QR code at the end too, linking to them. So these are questionnaires or other evaluation tools that I've used or found helpful in the past. The continuing education, I'm sure, not 100% sure, but pretty sure you're probably doing the MBS IMP student version. But when you're done with that, and once you're CF, you can get your full certification. There's also the McNeil Dysphagia Therapy Program that I've mentioned to you. There is an out-of-pocket expense, and it is a three-year certification. But again, out of everything I've done, I'd say that was the most worth my time, and no one's paying me to say that. Similar to that, this is more on my bucket list of things I'd like to try and to do, but the rest esophageal sweep. There may be other esophageal screening protocols or trainings too, but really looking at the full swallow. Oftentimes in acute care, we will get a case for someone that has more of an esophageal dysphagia, but they'll start with us. So it's really helpful to understand that and be able to point them in the right direction towards a GI consult, but knowing what you're seeing. There's also, I mean, there's continuing education through ASHA, of course. TIMS Medical is a type of unit that is used for video fluoroscopy. They provide a bunch of free continuing education courses, and then there's also MedBridge or Medical SLP too. Those do cost money, but it's fairly reasonable, and I believe that there are student discounts for them. And then lastly, social media is actually growing in its resources. So lots of voice centers or medical institutions will post modified barium swallow studies or fees, and they'll talk a little bit about the cases. And I found that that has been a really nice way to learn something or see something that I've never seen. And it's just kind of incorporated into my everyday. So I'd highly recommend something like that, where there's the Swallow Your Pride podcast too. I haven't listened to it personally, but my coworkers really enjoy it. Thank you so much for listening to all of that. Hopefully, some of it was useful. I'm really excited for you, and I know you'll be great in whatever field you end up in. If you have any questions, feel free to contact me at elizabeth.rinkert@uky.edu. Always happy to chat further. And here is the QR code for my references and additional resources, papers, programs, and things that I found to be helpful.